You see the title is Disturbances of Growth Neoplasia. This is one of these, well, probably the only time in the sequence where pathology really meshes with what else is going on. What I mean is we'll spend much of the 2 hours today and then an hour Wednesday on the subject of neoplasms, that is tumors. This will feed into Dr. Gruber's 11 o'clock lecture on Wednesday on the genetic aspects of neoplasia, and then a very interesting MDC in the afternoon dealing with some clinical aspects of those same things. But before we settle down to the subject of neoplasms, tumors as such, I want to spend a bit of time giving you a few notions and definitions and visual images dealing with other abnormalities of growth, short of neoplasia. In other words, there are some other disturbances in the size of cells, tissues, and organs, the mode of cellular proliferation, and even the way that cells mature. And we'll look at a few of these abnormalities first before we get on to the main subject. Let me begin very simply with situations in which you might encounter a bunch of cells, a tissue, an organ, smaller than normal, smaller than you expect. And it runs something like this. It makes pretty good sense that the one way you could end up with a tissue that's abnormally small or an organ that's abnormally small is a developmental situation where it never grew up. Sort of a dwarfed tissue or organ. And on the other hand, there are situations, as I think you're already familiar with, when an organ or a tissue reaches a definitive adult size and then shrinks. That process, I think you know from Ramsberg's lecture, we'd call atrophy. So those are two kinds of situations. And I want to run through first this list of developmental problems that we encounter from time to time. Now, the most complete sort of defect you might encounter is when the embryonic rudiment of an organ simply doesn't develop. It's a screw up in embryogenesis, and there's no organ laid down. And we refer to that process as agenesis. There's a slight variation on the theme, and that is where the rudiment of the organ may be laid down in the embryo, but the thing never grows. You end up with a nondescript nubbin of nothing, and that's sometimes referred to as aplasia. Those two terms are essentially synonymous. It's an absence, really an absence of the tissue. And I'll give you an example, a very striking example of this. Here's an autopsy specimen. Let me orient you to it. This is the urinary bladder down here. Here is a ureter on one side going up and connecting with a very respectable looking kidney. Here's the other ureter. Boom. There was nothing outside. It's not a camera trick. There's nothing outside there. It just ended that way. Now, that is an example of unilateral renal agenesis or aplasia. I don't care which word you use. This sort of thing is compatible with a long, happy life, and this was strictly an incidental finding. I don't remember anymore what this individual died of, but it had nothing relating to the urinary tract. So it's just a failure on one side for that kidney to develop, agenesis or aplasia. Sometimes we see this bilaterally. Both kidneys are not there. And that, of course, is not compatible with life, whereas this sort of thing is. Now, the next step up from agenesis or aplasia is a situation where the organ rudiment is laid down in the embryo, and indeed it grows, but not as much as it should. So you end up with something smaller than normal because of well, I might call it loosely a growth failure, and that we call hypoplasia. Hypo meaning under or less than. And there's an example. Let me take you through this one. It's a little bit confusing. Here's the bladder. Now this happens to be the aorta. Forget about that. Here's the bladder. Here's the ureter on one side going up to a very decent looking kidney. Here's the ureter on the other side, sort of stunted, And here's a little shrunken, well, I shouldn't say shrunken, but a tiny miniature kidney there. That represents a unilateral renal hypoplasia. Again, sort of an embryonic defect, if you will. Sometimes we see this bilaterally, and it could be all degrees. It could be something between this and this, or something even less than this. And as long as, you know, you put it under the microscope and you see the structure of kidney, but there's not enough of it, it's too small, that's hypoplasia. Now, I've shown you urinary tract here. These sorts of defects, agenesis and hypoplasia, occur in other organ systems as well. I just happen to have these pictures on hand. One of the things you'll encounter when you get over in the hospital, because we are sort of a funnel for odd things, is fairly often kids born with what we call hypoplastic left heart. And that's a situation where the chambers of the left side of the heart, and even sometimes a portion of the aorta, simply don't develop properly, and they're little tiny nubbins on the heart. And this hypoplastic left heart syndrome is lethal unless some pretty fancy surgery is done to intervene for a while. So you will see that hypoplastic left heart. One more term on that list that I gave you, I just define it and I won't illustrate it, and that is atresia, A-T-R-E-S-I-A. Atresia, which is a situation, again, it's a developmental failure where a channel, a normal opening or channel, fails to stay open, fails to form properly, so you end up with a closure where you should have a channel. Something, let's say, along the GI tract or along some kind of a duct where suddenly it simply disappears because it never opened up properly. That's atresia. Now, the second situation I mentioned back on that list, other than developmental, is a situation where the organ has reached the definitive size and undergoes the process of atrophy. Atrophy can come about really in two ways. First of all, every single cell in the tissue could shrink by some percentage, and that would produce a smaller tissue, a smaller organ, or a certain number of cells. Let's say you start out with 1 million cells in the population, and some of them disappear by apoptosis, and you end up with 800,000 cells. That's going to be a shrunken tissue. So a tissue can undergo atrophy with shrinkage of individual cells, and sometimes loss of cells, or both. But it's a secondary change after the organ has reached its definitive size. Some examples of atrophy, as some of you may know already, is perfectly physiologic in the, let's say, in the fetus. As various things form and come and go, there's atrophy. There's certainly atrophy of fetal structures in the neonatal period. Umbilical vessels and that sort of thing undergo atrophy. There's examples of physiologic atrophy as one matures into adult life. The tonsils shrink. The thymus shrinks, and so forth. There are these things which are expected and physiologic. When it comes to pathologic forms of atrophy, there are many reasons why this can happen. One that Dr. Ramsberg may have mentioned is ischemia. If you rob a tissue of its blood supply, let's say not enough to kill it, but really to cut it down, there's such a thing as ischemic atrophy. And you'll see that in arteriosclerotic areas where the tissues tend to simply shrink. Starvation. You don't feed a person enough calories. Starvation will produce atrophy. There's a hierarchy of organs which I don't want to go into. I mean, for instance, the brain doesn't atrophy in that situation, but the adipose tissue does, the liver does, and so forth. That's starvation atrophy. In the case of muscular tissues, disuse, just plain old disuse, will cause atrophy. And it can be very striking. I don't know if any of you have been in this situation, but you have an acute injury like, let's say a bad knee for some reason, just self-splinting. Not using that leg in the same way will cause a shrinkage, and within a few weeks you can get a loss in circumference of a thigh, let's say. Or I don't know how many of you are skiers that have gotten into trouble and ended up with, let's say, a cast on an extremity for a number of weeks, and when that cast comes off, you've got a shriveled leg compared to the other one. That is disuse atrophy. An extreme example of that is something we call neurogenic atrophy. If you cut the motor nerve going to a muscle, and that muscle can't work at all, and it's getting no signals, it'll really shrink. It's a tremendous sort of atrophy. Then, I'll stop this list with one more. Many tissues in the body are the way they are because they have a certain endocrine support. They depend upon a certain level of a particular hormone, and if you withdraw that hormone, the tissue will undergo atrophy. Morphologically, it's pretty straightforward. I'm not going to show you much of this. It's simply the tissue is smaller. You look at it under the microscope, and the individual cells are smaller. The number of cells, that's a tougher thing to deal with, but basically it's a small tissue. Sometimes there's partial fibrous replacement as the tissue shrinks, and we call that fibrous atrophy. Sometimes there seems to be an increase in adipose tissue marbling the tissue. We call that fatty atrophy, but basically the business cells of the tissue are smaller. There's one variation on this theme that Ramsberg may have introduced you to, and it's this, that as a cell shrinks, it basically is undergoing a process of autophagy. It's eating itself. It's digesting various of its organelles and so forth. And one of the things that happens from this digestive process is that there may be residual products left afterwards, and they tend to be pigmented products, which we refer to as lipofuscin. You had that term defined? Well, here's a liver where, particularly in this area, this central area, the cells are shrunken. And you'll notice, it's not a particularly good photo, Mike, but you'll notice that they are brown. And that's because of a relative concentration of lipofuscin there. They've been undergoing autophagy, and the residual products are piling up. And sometimes we refer to this as pigment atrophy or brown atrophy. And I've seen shrunken livers where there's perhaps half the mass of the usual liver, and they're really a definite brown rather than the ordinary liver color because of this sort of accumulation. Okay, so much for smaller than normal. Let's go to the flip side and look at situations where the tissue or the organ may be larger than normal. And this can come about in two ways. Again, you can have increase in the size of the cells in the tissue, and we refer to that as hypertrophy. And you can have an increase in the number of cells in the tissue. We call that hyperplasia. Now let's go back up to hypertrophy. Let me point out that size increase isn't simply cell swelling. You know about the phenomenon of cell swelling, which involves a net accumulation of water. That we wouldn't call hypertrophy. In hypertrophy, the cell is enlarged because of an increased synthesis of cellular components. I'll show you that in a moment. Again, hyperplasia involves an increase in cell numbers, so you would look for hyperplasia only in tissues that are capable of dividing in the adult state. In other words, a permanent sort of tissue, you're not going to get hyperplasia. You're not going to get hyperplasia ordinarily in muscle. You're not going to get hyperplasia, well, muscle is probably the best example. But in other organs, you may get hyperplasia along with hypertrophy. But conceptually, hypertrophy is increase in cell size, hyperplasia is increase in cell number. The best examples of hypertrophy are in muscular tissues. And it's a response, hypertrophy in a muscle is a response to an overload or an unusual workload or whatnot. Now, you need a lot of imagination for this, but imagine that I went in for bodybuilding, which I never will. And you know, you pump 300 pounds like this, and after a while, couldn't get into the lab coat. Bulging muscles, I told you, imagination. But the muscles of the bodybuilder. You've all seen pictures of this, and maybe some of you are into this sort of sport. This represents hypertrophy of muscle. There isn't any real increase in the number of muscle cells, but any individual muscle cell, instead of being this big around, is this big around. And it represents actually a synthesis of more contractile machinery in the muscle. It's a response to the work. Now, a place where we see this where it isn't so trivial is in, for instance, heart muscle that is subjected to an abnormal load. Picture, for instance, a left ventricle having to pump blood in a patient with uncontrolled hypertension. In other words, the systemic blood pressure is elevated, the arteriolar resistance is there, and every time that poor old left ventricle tries to eject blood, it's doing it against an increased head of pressure. Those muscles are going to undergo hypertrophy. Or, let's say the valve, the so-called aortic valve, which is a valve between the left ventricle and the aorta as the blood flows out. If that valve gets narrowed, the poor old ventricle has to squeeze harder to get the blood out to maintain life. It will undergo hypertrophy. Not hyperplasia, but hypertrophy. And the heart gains weight, the ventricle becomes thick, and the cells become enlarged. And I'll illustrate this for you. Here's, don't pay attention to the color. There have been some post-mortem changes here, but this is a bread loaf slice of a normal heart. And you're looking at the right ventricle over here, the left ventricle over here. Ordinarily, this is normal. The right ventricle is very thin because it pumps against a lesser head of pressure in the pulmonary circuit. And then the left ventricle, that's about normal thickness. Now, the next slide is not a photo trick. And again, don't worry about the colors. But the next slide is taken from an individual with high blood pressure. Now, that first heart probably weighed in the neighborhood of 300, 325 grams. This heart weighed closer to 600 or 700 grams. I don't remember precisely, but it kind of speaks for itself. There is more muscle there. And again, this is not hyperplasia, this is hypertrophy. And it looks something like this. I know you don't know much of this histology maybe, but just think of these as cross sections of these cylindrical muscle cells. And this is a normal myocardium. And just cast your eyeballs around and look at about the approximate average diameter of those cells. The next slide is taken with the same optics in the microscope from the hypertrophic heart. Now, you got this? See the point? Those cells are really increased in diameter. Don't worry about this. I don't expect you to pick this up on a quiz, but just to show you that increase. And what this represents really is an increase, a very striking increase in the myofibrillar contractile machinery of these cells. So this is clearly an adaptive phenomenon. And it works very well up to a point. Now, the heart can't keep getting more and more and more and more hypertrophic. I've never seen a heart weighing much more than 1 kilogram, and that's rare. But beyond that, it doesn't work. And one of the reasons it doesn't work is that the vascularity of the blood supply of the heart muscle doesn't keep up with too much hypertrophy, and pretty soon the muscle to capillary ratio is unfavorable and it plateaus. It can't go any further. And then what you get is the onset of apoptosis in cells and actually some fibrous replacement of the myocardium, so it doesn't work indefinitely. And actually, some of the proteins that are formed are not necessarily normal either. So hypertrophy is nice and adaptive up to a point, but beyond that, it fails. Just might mention before we leave hypertrophy that this also goes on in other types of muscle. As you may know, for instance, the wall of the urinary bladder is muscle, but it isn't this kind of muscle. It's what we call smooth muscle. But if there's chronic obstruction to bladder outflow, you get a very thick muscular bladder. It's the same kind of response, a hypertrophy of the muscle cells. When we turn to hyperplasia, there are lots of examples I can give you of increase in the number of cells in the tissue. And a nice example, I think you've all been there in one way or another, is a callus that forms in the skin. You know, if you have an ill-fitting pair of shoes and something's rubbing on a spot, or God forbid, if you have to do manual labor for some concerted length of time, you develop calluses. You've all had this happen. And this is an example of hyperplasia. It's a response to this overwork stimulus, which increases or leads to an increase in the number of cells in the system. Now let me illustrate this, give you a little histology. This is basically a normal skin of the sort you find in the palmar surface of the hand. This is the dermis, the connective tissue part of the skin. This is the epidermis, the epithelial portion. Now this is a renewing cell system. Normally, a certain number of cells are mitosing down here in this basal layer, and then the daughter cells are moving out and maturing as they move on out. And this upper layer where you see no nuclei is the so-called stratum corneum. It's like a layer of shingles on the roof. These cells undergo progressive changes and get this bit of armor plate here. So the normal palmar skin is set with a certain cell population and a certain balance. The cells come and cells go, but that's what it looks like. Now, I'll show you the callus. Keep this picture in mind, and this represents the hyperplasia of the callus. Now, you've got a much thicker cell population. It's still a very orderly cell population. The cells are being born down here, and they're maturing up towards here. There's actually so much thickening here that I couldn't get it all on one picture at the same magnification. Here is the beginning of the stratum corneum. There's the rest of it. And that's kind of the pad of the callus. So you see there's been a tremendous hyperplasia here in response to this mechanical stimulus. Now, the nice thing about hyperplasia, and it also applies to hypertrophy, if you get rid of the noxious stimulus, things pretty much wind back to normal. You can't always do that, but if you can, if you quit raking the ground or whatever you're doing, pretty soon those hands will be the ones you know and love. The callus thins out and you go back to normal. Now I could give you other happier examples maybe. I'll give you one. In a hormone-sensitive tissue that responds with hyperplasia. Here is a normal lobule. This is kind of a potential secretory unit. Normal lobule of an adult female breast. I don't want to go into detail, but just to show you those little terminal units forming this lobule. During pregnancy and lactation, with this tremendous hormonal stimulus to these cells, they undergo hyperplasia, and that lobule, take a look at the size there, would enlarge. I couldn't even get the whole lobule on the screen there. This is in a lactating mammary gland. There's a tremendous increase in the number of cells. Actually, there's some hypertrophy of individual cells too, but basically a whole lot of hyperplasia there in response to the hormone. When the hormonal stimulus is withdrawn at the end of lactation, things pretty much go back to normal, plus or minus a little stretching of the connective tissue, but the epithelial population goes back to normal. So that's hyperplasia. It tends to be reversible under a very nice, elegant control. In some situations, I've got to throw this in, it's not all good news. In some situations, the hyperplasia isn't necessarily adaptive and good. We see examples of hyperplasia, I'll show you two of them, that are probably, underline probably, responses to subtly abnormal endocrine stimulation somehow. We don't exactly know. But I'll give one for the guys and one for the girls. This is something that's going to afflict about 49% of us in a room, one way or the other. And this is a cross cut of the prostate. Now, the prostate normally is about the size of a golf ball, no, a little less, walnut, good sized walnut. And it's right at the base of the bladder, and the urethra, the outflow tract, goes through the prostate. So you're looking at a cross section here, and you see the urethra there. The normal prostate would be nice and smooth across the cut surface. Here you see a bunch of lumps. And this represents hyperplasia. Prostate is a glandular and muscular tissue, and the glands undergo tremendous hyperplasia. We don't know why. And the problem with this is not simply walk around with a tennis ball there instead of a walnut, but it presses on the base of the bladder and on the urethra, and it can cause outflow problems and all sorts of urinary tract problems. I'll give you a little tidbit that's absolutely useless. Eunuchs don't get prostatic hyperplasia, but it's not a very popular preventive measure. So there's an example. It's not a neoplasm, it's strictly hyperplasia, but it's out of kilter and not good. For the rest of you, we'll talk about a very common condition called fibrocystic change in the breast. Now, this is a nondescript-looking piece of tissue, but it's breast tissue, and if it were perfectly normal, it would mostly be the yellowish background, because the breast is largely fatty tissue, and not those big yawning things there. What's happened in this breast is, first of all, there's an increase in fibroblasts, fibrous connective tissue. You see these white streaks, and this represents part of the duct system where the cells have increased in number and fluid is accumulated, producing what we call cysts. A cyst is a hollow space filled with fluid and lined with an epithelium. And so we call this fibrocystic change. It's in and of itself, it's very common. In and of itself, it's no big deal. But I'll show you what happens conceptually here. Here again is the normal breast. This is a lobule, like I showed you before, and this is part of the duct system leading to that lobule. That's normal. Now, in the fibrocystic change, what you see is this sort of thing. Here's a lobule that has undergone hyperplasia. Pretty evident. In the duct system, the lining has also undergone hyperplasia, and you see these ducts are dilating and eventually will form those cysts. And again, we don't know exactly why this happens, but it represents hyperplasia gone wrong. All right, moving right along. What I'm doing is just picking off these concepts. You can follow this in your reading too. I want to switch to something a little bit different and talk about a couple of aberrations in the proliferation and maturation of cells in a population. And we're talking about two particular situations here. We'll talk first about metaplasia and then dysplasia. All right, what about metaplasia? We define this as a change in the cell population in which one normal, mature, specialized cell, I'll clarify this in a moment, but one normal cell type is replaced by another normal cell type, except it doesn't belong there. In other words, it's changed for that particular location. Now, this isn't just a substitution. This isn't a situation where this cell sitting here suddenly changes into another cell. What this is, rather, is a change in the maturation of stem cells in that population. You've got a proliferating cell population where ordinarily the cells mature in this direction, and metaplasia represents a switch under some influence where they mature in that direction. And I guess I could say that minor irritative, or maybe not so minor, irritative stimuli can produce metaplasia, and we argue sort of teleologically, we say the new form of tissue may be more resistant than the normal one, and that represents metaplasia. Let me illustrate this, try to make sense out of it. Here is the lining of what we call the endocervical canal. This is the canal that goes up into the uterus. Now, normally, what's going on here is there are a certain number of, well, call them stem cells or reserve cells down here that are proliferating all the time, but they mature into these tall, what we call columnar cells. See, they are tall and columnar, and they've got very pale cytoplasm because they're full of mucus. So normally, this endocervical canal is lined by this mucus-secreting epithelium. Very slight stimulus is all it takes, and there may be a change. Here you see the normal, here you see the normal, and here is a plaque of cells that looks a little bit different. And these cells are, well, they're odd shapes here, but they're maturing into these flattened sort of cells that we saw on the top of the epidermis. And we call this, these are columnar cells, these are squamous cells. We call this squamous metaplasia. Very, very common. Some of you in this room have this. It's a trivial change, practically ubiquitous in adult females in the endocervix. It can become quite extreme. Look at this. This whole area should be lined by these columnar cells that look like this or like this, and instead you've got what we call here a squamous or a stratified squamous epithelium. It looks a lot like the epidermis did, doesn't it? And what I would emphasize a couple of things. Well, one thing in particular is that this is perfectly orderly. If you looked at this, I know you haven't become histologic experts yet, but if you looked at this, you say, well, that is a perfectly orderly squamous epithelium. Nothing unusual about it, except it doesn't belong there. So that's an example of metaplasia. In and of itself, trivial, or even protective. Let's say chemical workers who are exposed to fumes might develop this kind of metaplasia, the lining of their trachea and bronchi, and you could argue that that makes them more resistant to whatever they're inhaling. Smokers develop this sort of thing. Now, this could go on, and something else might happen, and this might lead to bad things, but in and of itself, metaplasia is perfectly innocent. Not so with dysplasia, DYS, P-L-A-S-I-A. Now, morphologically, let's talk morphology first. Dysplasia is an alteration in the proliferating cell population which leads to abnormal variation. Just underline that word variation. Abnormal variation in the size of the cells, the shape of the cells, the arrangement of the cells, and the maturation of the cells. Too much variation. In other words, instead of something very well controlled like this epithelium is very well controlled with all the cells down here proliferating at a certain rate and maturing gradually and so forth. All this gets screwed up in dysplasia. Now let me illustrate it and we'll talk about it a little bit. Here again is a normal squamous epithelium. This isn't Palomar skin now. This is in the, let's say the lining of the vagina or the covering the cervix, one of those things. This happens to be cervix. Perfectly normal squamous epithelium. Notice how orderly it is. It's like kind of like a parade where you have cells of a certain type down here. They all resemble one another in this layer. Cells here resemble one another. And then there's this maturation, these flattened out cells, and that's occurring in a very orderly step fashion. In dysplasia of an epithelium like that, everything gets screwed up. All right. All right, this is dysplasia. And you can see where there's a shadow of what you looked at in the preceding slide, but now some things have happened. There's more variation in any layer. In other words, you look down here, and these cells are more variable than those cells were in the basal layer in the normal. You look here, where in the preceding slide, every cell in this intermediate zone was perfectly like every other cell. There's variation here. There are big cells and small cells and round cells and elongated cells, cells with very dark nuclei, cells with lighter nuclei, and so forth. And gradually, though, despite this mess, there is slight maturation here. You can see how this jumble of cells gradually becomes organized up here. So what have we got? We've got abnormal variation in the size of the cells, the shape of the cells, the arrangement of the cells. And this is out of order. It's not in a nice, neat lockstep, and it's not maturing quite properly until it gets to the very top. And this is trivial for you now, but we grade dysplasia as slight, moderate, or severe, depending on how much normal there might be there. But when you see this degree of variation, that's a very bad thing. There's one other thing that's abnormal here. It's a little more subtle. Ordinarily, mitosis occurs only down in this basal layer. But these cells are goofy enough that they forget about that, and they do something very impolite. They reproduce out in public. And you find mitotic figures at all levels of such an epithelium. So morphologically, this represents a lot of variation. This is a serious change because these cells are, in a sense, losing control. They're losing control of their proliferation and their maturation. And this occurs, we realize now, from a number of mutations that occur in the cell population. This reflects genetic changes in these cells, somatic genetic changes. And accumulate a certain number of these mutations, and this happens. And this, I want you to remember for the rest of your lives. Dysplasia may be a step towards cancer. That is its significance. Now, it isn't 100% obligatory. In other words, I can't say that epithelium absolutely for sure will become cancer. It depends, I would suppose, in the last analysis on the number of mutations and the type of mutations acquired. But let's say mild degrees of dysplasia sometimes don't necessarily progress, whereas very severe degrees of dysplasia, if left alone, not taken out, if not treated somehow, will march right on to a cancer. So when you have a patient who has a diagnosis of dysplasia in some tissue, watch out. It calls very close scrutiny. In the severest, here is a squamous epithelium with what we call severe dysplasia, and you can see close up what's going on here. This basal layer is increased in thickness, a lot of variation in these cells. Here is a cell dividing, as they say, out in public, and there is absolutely a total jumble in terms of how these cells are arranged with respect to one another. We call that a loss of polarity. And in this instance, it occurred all the way full thickness of this epithelium. And we now know from a lot of experience that severe dysplasia really is tantamount to cancer that perhaps hasn't yet invaded. Now that'll make sense when we talk about what cancer really is. But without any evidence of invasion or anything else that cancers usually do, when the dysplasia is this severe, we can say this is like carcinoma in situ, which means an in-place cancer, a pre-invasive cancer. Because we know if this sort of dysplasia is left alone, probably close to 100% will evolve into a cancer if the patient lives long enough. And while I've got this on the screen, I'll point out that there's some cytologic changes that are very important in making this decision. First of all, you'll notice there's a lot of variation in the size of nuclei. We call that nuclear pleomorphism, P-L-E-O, pleomorphism. That's a bad sign. I mean, none of these is absolute, but it's a bad sign. Some of the nuclei are very dark compared to others as you cast your eye around here. We call that nuclear hyperchromatism. Too much colored material in the nucleus. The nuclei are very unusual shapes. And sometimes, you can't see it particularly here, sometimes the mitotic figures themselves are even abnormal. We may see a tripolar mitotic figure or something like that. These are all signs of badness in that cell population. Again, if something like this is left alone, it will proceed to an invasive cancer. So we refer to this as carcinoma in situ until it invades, and it's the full thing. Okay, draw a line under all of this, and now I'm going to turn to the main topic, that of neoplasia. Spend the rest of this morning and Wednesday morning on this topic. It's sort of the ultimate disturbance in growth. All right, what is a neoplasm? I think we all have some notion, in fact, we had somewhere about a tumor, about cancer, about something, but let's do it carefully so we're all on the same same page. A neoplasm, and the root means new growth, neoplasm, is a mass. It's a lump. There's more cells than there ought to be. It's an increase in cells. It's a lump, basically, of cells. And these are proliferating cells. They're not just sitting there. They're dividing and making new cells. And they're cells that have somehow, and we'll talk about that, and Dr. Gruber will talk about that in detail, these cells have become autonomous to a significant degree. Now, they still need oxygen and nutrients, but they've lost their dependency on the usual trophic influences, and they basically don't obey the same stop and start signals that normal cells do, and their growth tends to be excessive and uncoordinated with the needs of the host. In other words, this thing is taken off on its own, it's kind of rebellious, it's, I'm going to grow, I don't give a damn what's going on over here, I'm not listening to your signals anymore, it's autonomous. The neoplasm, if you want to think teleologically, serves no useful purpose. It's not adaptive. And generally speaking, even if you withdraw the provocative agent, once the neoplasm is formed, it is off and running, which is different than hypertrophy and hyperplasia, where if you withdraw the stimulus, it goes back to normal, or potentially does. But, so there's an element of irreversibility in neoplasm. In terms of terminology, in English-speaking countries, the word tumor now is used practically synonymously with neoplasm. You learn tumor as one of the cardinal signs of inflammation. And the old meaning of tumor simply meant swelling. But when you say a patient has a tumor now, you don't mean it's swollen, you mean he has a neoplasm. So tumor and neoplasm, about the same thing. And as you probably have noticed, the suffix OMA usually denotes a neoplasm of some sort. There are exceptions. A hematoma is a lump of blood. That's got nothing to do with a neoplasm. But most omas are neoplasms. And there are two big flavors of neoplasm distinguished by their behavior. I think you all know this: benign and malignant. Cancer is a general term that refers only to the malignant neoplasm. I don't want to insult you, but just so we're on the same page. There are many neoplasms that are non-cancerous. It's only the malignant ones we refer to as cancer. Again, look at all of these characteristics, and they're very different than hyperplasia and hypertrophy, which are generally adaptive. They're under very careful control, and they're reversible when the stimulus is withdrawn. And neoplasm is very, very different. Now, the basic unit of a neoplasm is a living, proliferating cell. And these neoplastic cell populations are derived from previously normal cell populations. And it's a series, it's a multi-step series, an accumulation of genetic events that Dr. Gruber will describe for you. I don't have time now. But these lead to what we call neoplastic transformation, basically. And we speak of transformed cells as cells that have acquired a set of these new characteristics that define them as neoplastic. And as you will hear, usually a neoplasm is basically a descendant of one cell that has acquired just the right just the wrong mutation. So we talk about the clonal origin of neoplasm. In other words, the neoplasm is the clonal proliferation of a transformed cell. Now, the neoplastic cells, these transformed cells, have a lot of characteristics of behavior that are quite abnormal. In fact, you can see this in vitro. When you culture malignant cells, for instance, they loss of control, the usual control of movement that they display on the surface of a plate. There's loss of, ordinarily there's a control in a cultured cell population where when the proliferation reaches a certain point it stops. Not so with cancer cells. Well, I could go on there. There are many different things that occur in vitro and in vivo. In the host, these transformed cells relate to the host in very aberrant ways. As I say, they're pretty much autonomous. They don't listen to stop and start signals, and they manifest a really non-equilibrium growth. In other words, at some rate or another, they're going to keep on expanding unless something is done. The other thing that will strike you, I'll just mention in passing, is virtually any tissue in the body can give rise to neoplasm. You will learn that there are members that are high on the hit parade for reasons we're just beginning to understand, but any tissue potentially can give rise to neoplasm. Now, what about the difference between benign and malignant? And I think this cartoon, which is pretty crude, sums it all up. These are behavioral characteristics. Now, in the benign neoplasm, as the neoplasm grows, as the number of cells gradually increases, they tend to be cohesive. I'm not giving you reasons for this, just description. They tend to be cohesive, so that as the neoplasm grows, and it may grow to a very large size, it tends to grow by a centrifugal expansion. Now, it's not perfectly spherical, but it tends to grow by expansion. And as it expands, it frequently will even pick up a condensed capsule of connective tissue as it pushes out, causes atrophy of surrounding tissue, and it will accumulate kind of a capsule almost. In any rate, it stays mobile, whatever it is the size, and it doesn't invade adjacent tissues, it just pushes them out of the way. Or it may press them to death, but it's like blowing up a balloon in the tissue. On the average, now this isn't a defining characteristic, but on the average, benign neoplasms grow more slowly than malignant. But that isn't part of the definition, because there are some slow-growing malignancies and some rapidly growing benign neoplasms. But if you compare the averages, they tend to grow more slowly. Now, malignant neoplasms are not as cohesive as this suggests. As it grows, the cells have a great tendency of leaving what we call the primary. They tend to drift and move away. They don't obey the stop and start signals. They have a very different relationship to the extracellular matrix, and basically they have the ability, and this is a defining difference, they have the ability to cut their way, I'm using that figuratively, cut their way through the adjacent stroma and actually invade it as clumps of cells, lines of cells, individual cells. Invasion is one of the defining characteristics of malignancy. Now, I said the malignant ones tend to grow faster than the benign ones. That's not a defining difference, but invasion is. There's no such thing as an invasive benign neoplasm, property of malignancy. And there's one other, well, this sums it up: cohesive, expansile, circumscribed, localized. That's benign. Malignant is poorly circumscribed, invasive, metastasizing. That means it can spread to distant foci. We'll talk about that in just a moment. But it's invasion and metastasis that define malignancy. Benign neoplasms do not metastasize. Benign neoplasms do not invade. All right, this is a test. See if you can become pathologist now. Here's a uterus cut sort of in sagittal section. This is the cervix down here. This is a normal one half. This is the uterine cavity here. Here is a neoplasia. Benign or malignant? See? It works. This is what you probably grew up hearing as a fibroid, a uterine fibroid. That's a misnomer because it isn't a fibrous tumor, it's a muscular tumor, one we call, and we'll get into this Wednesday, a leiomyoma. But you can see it's got, just like the cartoon, it's got pushing edges. If we look at that microscopically, same sort of thing. Here is the tumor, here is the edge along here, no invasion, just pushing. You can almost see it pressing on that adjacent muscle. Here's a breast that's been taken off, a mastectomy specimen, and it's been cut kind of in this plane, a section, so you can see the skin out here, and this is the neoplasm. Very, very hard to define and circumscribe. It's going out in little spikes into the adjacent tissue. Even way beyond this microscopically, there were lines of cells that you couldn't see here. That's invasion. A benign neoplasm wouldn't look like that. Here's one that's a little deceptive at first. This is a colon cancer. We've opened the colon and washed it off. And you might say at first, well, gee, that's circumscribed, isn't it? Well, not exactly. You can see kind of tongues projecting. And what I did here was fix this in formaldehyde and then made a cut across it. And it looks like this. Now, this doesn't look so awful, but it really is. Here's the normal mucous membrane up here. This layer we call submucosa. This is the muscular wall of the colon here. Here is that mushroom, and you can see this whitish tissue, this is neoplasm, invades all the way through that muscular layer. This is invasion. This is what it looks like microscopically. You don't worry about this. These dark cells with the hyperchromatic pleomorphic nuclei and so forth are the cancer cells, and they're cutting right through that colonic wall. It's not that simple, but they're cutting right through that colonic wall and invading. That constitutes the evidence that this is a malignant neoplasm. All right, let's take a break for about 8 minutes, and then we'll catch this up.